All right. Welcome everyone to our GaPQC Neonatal June webinar. We are excited to have everyone here today and excited to have our speaker. And we are going to start with a few updates on the initiative, some logistics, and then we'll get into our featured speaker, Dr. Michelle Pina. So again, I wanted to welcome everybody today. This is our official launch of the Optimizing Newborn Nutrition in Georgia initiative. You'll notice we've changed the name a little bit, moved some words around. So we're officially Optimizing Newborn Nutrition in Georgia, or Optimizing Newborn Nutrition. Optimizing Newborn Nutrition is a 2-year hospital-based quality improvement initiative focused on increasing the percent of newborns with human milk as their first feeding and breastfeeding or expression within 6 hours of birth. I want to make sure everyone is familiar with our Neonatal Committee leadership. We have Dr. David Levine, who is the chair of our committee, Dr. Ravi Patel, who is the co-chair, and Dr. Taryn Fairley, who is the advisor to the committee. They are incredible leaders of this work and have been working with GaPQC for many years on other initiatives as chairs and co-chairs, and Dr. Fairley is an incredible expert in breastfeeding and is bringing a lot to the leadership of this committee, so we thank them. We also have a neonatal committee made up of members of public health, hospital systems, professional association, other organizations who have helped in the planning for this initiative and will be supporting the work as we move it forward. I also wanted to make sure you're familiar with the Department of Public Health faces that you'll be hearing from during this initiative. So of course, myself, I'm Kimberly Ross. I'm the Senior Manager for Neonatal Quality Improvement, and Shanta Rutherford is our Women's Health Evaluator. So you'll see emails coming through from both of us. So just wanted to make sure those names and faces are familiar to you. So just a little bit of an overview of the 2 tiers of involvement for the initiative. So teams can be involved as an active improvement team, which has 3 requirements, or a learning collaborative with no requirements. So for active improvement, those 3 requirements are that a team must identify project champions. So that's a project champion who's the primary contact for the initiative, and a physician champion. So that could be an OB, pediatrician, neonatologist, or an advanced practice provider like a midwife, PA, or nurse practitioner. And also they must demonstrate hospital support, so showing that senior leadership is in support of the project. And those active improvement teams are committing to tracking and submitting limited data. So that's audits once a month of 10 newborns, and we expect that to take less than an hour a month for those data submissions. So this shows where we are with recruitment and enrollment right now. We know with our learning collaborative, those are individuals and hospitals. We have 8 hospitals represented there in the learning collaborative who are participating in the webinars and the micro lessons at that involvement level. And active improvement, we have 18 hospitals with 27 sites represented. So hospitals, if they have a team that's a NICU team and a mother baby team, that counts as 2 sites within that one hospital. So we're at 18 hospitals and 27 sites. We are doing rolling enrollment. So if you're on this call right now and you have not submitted your enrollment form, that's perfectly fine. Those can still be submitted. We are accepting that. You can also move from learning collaborative if you decide in a couple of months that you want to do active improvement as a team. That's perfectly fine too. You can send that enrollment form to me. So we expect these numbers to change, but we're very excited about everyone who has enrolled so far and is ready to get moving with the initiative now. Just a little bit of information on how you'll be receiving resources and webinars and accessing micro lessons. Webinars are all recorded and they're going to be posted on Teams. So everybody who is a part of the hospital team or the learning collaborative will be a part of the team on Microsoft Teams, and we'll be able to access those resources there. Additionally, the micro lessons are going to be on Train. Some people are familiar with Train because it's used in other systems and CDC uses it. So that's a training platform that we're going to be using. There's a resource that will be posted on that Optimizing Newborn Nutrition team to show you how to set up a Train account. So that link will be sent out. If you are having any issues setting up that account, it'll walk you through how to do that. We need you to use the email address that you used on your enrollment form or your Project Champion submitted on the contact information form that they submitted for their team. This is going to help us connect you with the learning plan that we are providing. So we'll be able to troubleshoot any issues there, but for the most part, that looks like it's been everyone's hospital email address. But if it was something different that you enrolled with, use that when you set up your Train account. This will allow us to track who is taking the micro lessons. Each micro lesson will have a short assessment associated with it. So we'll be able to see which hospital teams have their members going through those micro lessons, how everybody is doing, and just help us see that piece of the learning. Additionally, the data collection for active improvement is starting in August. So monthly audits will begin in August, and the link will be sent out to the data collection contact who was identified by Project Champion. So again, Project Champions, if you have not submitted that contact form where you identify your data collection contact, please get that in to us. Links, if we don't have a data person identified, will go out to Project Champions. So that will go out on the 10th of the month. So August 10th, you'll receive your first link for that audit that will be looking back at July data. We ask that those be completed by the 20th of every month. So August 20th, we would love at the latest to have those back. You, of course, can do it on the 10th or earlier. We will be providing quarterly hospital reports back to hospitals and then a collaborative wide report looking at the collaborative as a whole. So the earlier we can make sure we're getting those data, we can stay on top of getting those hospital reports completed and to you so you can use that for your improvement work. I'll put this sample survey so you can see the questions up on Teams as well. You'll see it's very short. It's 8 questions. 3 of them are your hospital and the date and your email address. So it's even shorter than that. And so we don't expect this to be a very burdensome data collection project. It's not what it's about. But we do want you to submit these. Again, you'll get them on the 10th and we'd like them back by the 20th. Now we're going to move into a little information about the gap analysis and self-assessment that we will be walking you all through in our next webinar. And I was going to hand it over to Claire Eden with Georgia AAP to give you some information here.
Yes, hello, good afternoon, everyone. Sorry, there's so many sirens going on outside my window. I'm at my office in Midtown. I hope that's not too distracting. So yeah, Kimberly, if you want to move to the next slide, I'm just going to really briefly give you guys a little look forward. I think we've talked about where we're going, what our objectives are, and that's to increase the number of babies who are receiving human milk as their first feeding, whether that's term well babies or babies in your special care nursery or in the NICU. And also we want to increase the incidence of breastfeeding or expression of milk within the first 6 hours after birth. So we've chosen these because both these kind of measures have been shown to be really foundational to most other breastfeeding and lactation related measures and outcomes. So that's where we're trying to get. Next slide, please, Kimberly. We want to kind of first start with looking at where we're starting out. And to do that, we are encouraging hospital teams to participate in the National Survey of Maternity Practices in Infant Nutrition and Care, MPINC. Kimberly, I know there's a little like delay, but there we go. So the MPINC survey was in the field starting in August. If you wouldn't mind commenting in the chat if you've already completed the MPINC for your hospital, I'd love to get a picture of that. And also comment if you've never heard of the MPINC survey, so that we have a better idea about where our teams are starting. But the Maternity Practices and Infant and Nutrition Care survey is administered by the CDC. And so good, I'm getting some idea, a little bit of feedback here in the comments. So this, we're gonna send out a follow-up email to this meeting that has more information for you all. But this is a survey that's done every 2 years, and it includes all hospitals in the US, states, and territories that provide maternity care service. And I have lots more details, but I want to make sure we have time for Dr. Pena today. So great to hear that some folks have already completed this. The more of our hospitals in Georgia that complete this survey, the better the data that we have available to guide public health work around and population level work around breastfeeding in Georgia. It's also a really great opportunity for you all to meet as a team to review the questions and your answers. The kinds of questions that are on the MPINC survey, there's 6 core sections with an additional section for hospitals that have a special care nursery or NICU. And they cover early postpartum care practices, feeding practices, education and support of mothers and caregivers, staff and provider responsibilities and training, and then hospital policies and procedures in addition to your hospital demographics. So if you're not familiar, there's a really great, I'll put the link in the chat a little bit later, but you can read the Georgia report. Each hospital can submits their data to be aggregated. There's no, like, it's anonymous in that way, but you receive a report back. It's a benchmark report. So we encourage you all to review your 2020 or 2018 benchmark reports with your team as well. Next slide, please. So as Kimberly mentioned, some hospitals, we have a lot of hospitals participating that have a team both for mother baby and the NICU. And one of our kind of soft objectives of this initiative is to encourage more collaboration between these 2 units when it comes to getting lactation initiated. So we encourage you to meet together to review your previous MPINC benchmark reports and then to complete this year's survey together. Sometimes the NICU is considered sort of an exception in some areas around breastfeeding, but I'm not really sure why that is, because the provision of human milk is often even more critical for at-risk infants than it is for well babies. So this will be a good opportunity for you all to start that collaboration. Next slide, please. Oh, I see. Kim, thank you. You're right on it. She put the link to the CDC pages on the MPINC. Thank you, Kim. They're in the chat. And for those of you who don't have access to the chat, you will have an email with this information as well. So to get us started, next month's webinar will be focusing on a lactation gap analysis to help you kind of look at what's currently happening in your unit's culture, kind of harkening back to our previous webinars about sort of breaking up that old ice in the iceberg and looking at what's underneath too. I think we still haven't quite moved to the next slide, but maybe it's just a gap on mine. So in the gap analysis next month, we will be doing kind of some fun live assessment opportunities for folks to answer some polls around culture and policy and practice in your unit to help us kind of see where you are compared to other units or teams that are participating. And then we'll also provide a written tool for you all to use with some of those questions on it. And then that'll be kind of a way to get really engaged in looking so that you can start making some smart aims for your team. That's really most of what I had to discuss today. So just kind of give you a taste for next month. I am going to put, we have a slide with a couple other sources, and I'll put those links in the chat and the email if you want to do a little bit deeper dive into where your unit or your hospital stands compared to sort of best practices around lactation support in the hospital. So I'll put links to some of these in the chat, and also they'll be in your follow-up email. And I can't wait to hear Dr. Pena, because her topic is sort of another really big foundational piece of our initiative.
Great, thank you, Claire. And now I'm going to give it over to Dr. Patel, who's going to introduce our speaker for today.
Thank you, Kimberly, and it's wonderful to see all of you here. We're really excited to work with you over the next couple of years, really on kind of a shared effort, and collaboration is always a really nice way for hospitals to help accelerate improvement efforts and learn from each other. So I think this is we're really lucky to have Dr. Michelle Pena be our speaker to kick off this effort. And she is a neonatologist at the Children's Hospital of Philadelphia, and we are lucky to have convinced her that Atlanta is a lot better than the Northeast. And so she'll be joining the Emory University faculty as an assistant professor of pediatrics in July. Dr. Pena received her medical degree from Harvard Medical School and completed her pediatrics residency, chief residency, and neonatal perinatal fellowship at the Children's Hospital of Philadelphia. And she's also currently completing a Master of Science in Health Policy Research with a concentration in healthcare quality and patient safety at the Perelman School at the University of Pennsylvania. Her primary interests include health equity research with a focus on using implementation science and equity-focused quality improvement to address inequities in perinatal and neonatal care. She has written really a wonderful article that I'm going to put in the chat that I would encourage all of you to take a look, and I'm sure she's going to touch on this, titled Using Rising Tides to Lift All Boats, and Equity-Focused Quality Improvement as a Tool to Reduce Neonatal Health Disparities. And we hope over the next 2 years that we will be able to address some of these. And I saw a comment from Michelle Pratt in the chat, and we do hope to work on that related to improving equity and how moms and babies are cared for in Georgia. So without further ado, we're really excited to have Dr. Pena present today.
Thank you so much, and thank you for the invitation. I'm so excited to be here, and I'm really looking forward to moving to Georgia in just a few short days. I'm just going to share my screen. Okay, are you able to see my slides okay?
They look great.
Okay, great. I'm not able to see the chat, so please feel free to interrupt if folks have comments or questions as I'm sharing my slides. So thank you again, Dr. Patel, and to the GaPQC for this invitation. As you mentioned, my name is Dr. Michelle Marie Pena. I'm a neonatologist. I'm currently at the Children's Hospital of Philadelphia, and we'll be moving to Atlanta shortly. And I'll be presenting today on equity-focused quality improvement, a framework to address breastfeeding inequities in the newborn nursery. So I have no conflicts of interest to disclose. And here are my objectives, which are threefold that I'll go through today. So one will be to review the equity-focused QI framework, which I'll call EFQI, to apply EFQI concepts to a case study addressing breastfeeding inequities, and then to share some successes and challenges in applying this framework to real-life work. So before I start discussing EFQI and its concepts, I did want to start with a disclaimer, acknowledging diversity of practice settings. It sounds like there's people of all different levels of care, all different patient population, different communities, as well as different resource availabilities in different institutions and different hospitals.
Dr. Pena, we're getting a lot of static on your end. I'm not sure if there's
do you still have it now? Can you hear me?
Yep, we can hear you.
Is it still staticky?
That sounds a little bit better. If you want
to... Oop, how about now? I'm trying to see if maybe that adjustment helps. You okay to hear? You can hear okay now?
I think that sounds seems like it sounds a little bit better.
Okay, let me actually work on getting a backup set of headphones. Can you get me some headphones, please? Can you get me some headphones, please? Have my husband run back up here just in case we had some tech issues. So apologies for that. I'll work on getting the sound better. But as I was mentioning, one thing that I also think about as I do this work is sort of the concrete acknowledgement of myself and my own identity as a Cuban American female. And ultimately, my goal in this work is to take action by centering and amplifying patient and community voices. So throughout this presentation, I invite you to also think about your identities and what it is that you bring to your work. So Dr. Patel had mentioned we've been doing some work in this conceptual framework of equity-focused QI. I wanted to share a little bit more about it, as these are QI initiatives that integrate equity throughout the fabric of a project. They're meant to be inclusive and collaborative and prioritize and address the needs of groups that are experiencing a disparity. Key to equity-focused QI is that it's action-oriented. They're centered around equity, and ideally this is central in for a project throughout an entire project, not postdoc. So this means that you're using equity-focused QI principles at every stage of a project. Excuse me 1 second. I'm just gonna look here for my headphone cord. Which I may not find. Can you hear me okay now?
Sí.
Yep, that sounds good. We can hear you.
You can hear me? Okay. And so when we're talking about equity focused, oh, yes. Sorry, did someone say something?
No, yeah.
Yep, you're good.
Oh. So with equity focused QI principles, you're applying them at every stage of a project. And so as Dr. Patel mentioned, we define EFQI and share best practices in our manuscript and seminars in fetal and neonatal medicine. I think he said he was going to put a link to this article in the chat. And I really wanted to spotlight my co-authors, Dr. Reichman, Dr. Baccio, Ms. Madhu, and Dr. Montoya Williams, who contributed heavily to this work. And in this paper, we share 8 concepts or best practices in carrying out an EFQI initiative. And today I wanted to focus on 4 specific principles and then share our case study and our breastfeeding work to demonstrate how we've applied these principles. So to get started, the first concept that we talk about is the fact that to address the disparity, you have to first identify it. And this really emphasizes the point that looking at aggregate data may be misleading, and there may be buried disparities that you'll never know about if you don't look. So to start, we recommend stratifying QI measures by selected patient characteristics. And so when we talk about different patient characteristics, you've probably heard of real data. So that includes variables like race, ethnicity, language, and you can also stratify by other sociodemographic factors such as Progress Plus, which includes additional factors like place of residence, occupation, education, and other socioeconomic status variables. There's also other characteristics you can include, like personal characteristics associated with discrimination, features of relationship, time-dependent relationships. And I think especially when we're thinking about breastfeeding, there's even more variables to think about, such as what clinic a patient is being seen at, the mode of delivery, how many, are they their parity? Do they have other children, for example? Several other characteristics that could potentially impact their journey and in feeding their babies. And ultimately, when you're stratifying data, the goal is really to detect and then ideally target and monitor disparities over time. The second concept focuses on incorporating equity into every stage of a QI initiative. And the key here is really to remain intentional about integrating and centering equity. So it's talking about it and taking it into account at every stage. So for example, in QI, we're just talking about SMART aims. And we use SMART aims to make sure that our goals are specific, measurable, attainable, realistic, and time-bound. But instead, I invite you to create a SMARTY aim, where you're intentionally integrating inclusivity and equity into the core of your goal. I'd like to shout out one of our top improvement advisors, Tanisha Harris, who introduced me to this concept. So by putting inclusivity into your SMARTY aim, you're intentionally centering traditionally marginalized or minoritized groups into your QI work. And then by naming equity, you're intentionally working to address inequity. And this is also really important because we use our SMARTY aims to keep us accountable. And so by integrating these 2 additional levels, you're going to help keep yourself and your team accountable. So then the third concept is that families and community partners are critical stakeholders. So to do this, we recommend ensuring that families and community partners have a seat at the table. Ideally, this is from the beginning of a project, because this can really be an incredibly collaborative relationship, where families and community partners can provide input on project design, they can validate your framework and your priorities. I think one thing that we've learned, at least in our work, is that we can be quick to think that we know what the solutions should be, or that we have a sense of what the community needs. But I've learned, especially through this work that I'll share today, is that we may not totally understand what families and communities know or need. And so by collaborating with them, the work can really truly be patient-centered and community-informed, and hopefully more effective. And then the last concept that I'll review is concept 4, which is that the focus of the work should be on the evaluation of root causes and the modifications of systems and processes. And I think a big piece that I've learned with this work is that language really matters in these conversations. So when we're talking about stratifying by specific variables, these variables are not causes. Instead, you're measuring inequity and you're measuring injustice. So it's really critical as you're having conversations about, as you're doing these stratifications and as you're thinking about different ways to look at data and to look into challenges that families may be experiencing, that we have frank conversations about what terms you're using and what they represent. So for example, when talking about race, reminding the group that this is a social construct and being used as a proxy for racism. You can then use your QI tools to structure your evaluation of root causes as you would in traditional QI. So you can use your driver diagrams, your fishbone diagrams, and your 5 whys. And as you're having these conversations, being cognizant about focusing on modifiable systems and processes rather than individual behaviors. So we're not here to blame patients or groups of patients, but rather thinking about how our health system, how racism, bias, and social determinants of health are impacting the care our patients are receiving, and how we can better support our patients. And these conversations, I will say, can be definitely challenging and very uncomfortable, but are ultimately necessary to address inequities and create a culture of equity. So I'm going to transition now to share our ongoing QI initiative to address inequities in our breastfeeding initiation rates in the HUP newborn nursery. So HUP is the hospital of the University of Pennsylvania. I'll share a little bit more about it in a minute. And this work focuses in our well baby nursery. I did want to highlight my 2 mentors for this work, Dr. Chris, as well as Jen Peterman, as well as the rest of our incredible health equity task force, of which the work I'm presenting today is certainly not my own, but the product of the people that are on the screen, plus many more that are not pictured. So before I jump into some specifics about the project, I'll start with a little bit of background, although I don't think I need to convince you all about the benefits of human milk. And it sounds like there have been already conversations about the documented disparities that have been widely documented in the literature nationally. And when we looked at our data locally at the Hospital of the University of Pennsylvania, we noticed that we also had these same disparities described in the literature, specifically in looking at our exclusivity rates as well as our initiation rates. And so as we looked at these data, we decided to, as we first looked at our exclusivity rates, we looked upstream and wanted to tackle the disparities in our initiation rates. And when I'm talking about initiation rates, the operational definition specifically refers to having had a baby ever receiving any human milk while they're in the newborn nursery. For a little bit of context for HUP, this is an academic medical center, and we serve the West Philadelphia and the Greater Philadelphia communities, and we're part of the Children's Hospital Philadelphia Newborn Care Network. We have about 4,200 deliveries a year, and we're a designated baby-friendly hospital. You can see here the breakdown of the self-reported birth parent demographics, where over 65% of patients identify as Black or African American. And then our second largest group are families who identify as white. You can see here our baseline data. So we had actually been already tracking our breastfeeding initiation rates. And so you can see here on the left a run chart, where on the x-axis is date, so by month. And then on the y-axis, you can see breastfeeding initiation rate, and that's a percentage. And you can see on this run chart, the median that we had was 85%. However, if you stratify the data by race, you can see that while 93% of parents who identify as white introduce any breast milk, and this is the data in blue, 80% of Black parents introduce any breast milk in the newborn nursery, and that's the orange line. And specifically, as we were looking at these data, we had discussions about which group would be our comparator group, and wanted to be very intentional about that. And for this particular project, had patients who identify as white be our comparator group because it was the second largest group, as I showed in the breakdown of our patient population, and also this group had a higher breastfeeding initiation rate. I think one other thing to note, I will say we do have pretty high breastfeeding initiation rates. So that's something to keep in mind as we've been carrying out this project. And I think the other piece that to take away from this slide is really the striking disparity that you would miss if you hadn't actually stratified the data. So here you can see our SMARTY aim. I think overall our global goal was really to better understand the root cause of this inequity and really embark on a journey to learn how we can better care for and support parents who identify as Black or African American. So specifically our SMARTY aim was to increase breastfeeding initiation rates for Black patients in the newborn nursery from 80 to 85% by January of 2022. So to do this work, we created the Multidisciplinary HUP Neonatal Health Equity Task Force. And our group includes stakeholders from prenatal clinics, from inpatient OB and family medicine teams, inpatient newborn services, our outpatient pediatrics teams. And we quickly learned that this work required more than just our hospital and clinic stakeholders. We needed the community voice, and most importantly, this work needed to center around the patient voice, specifically the voice of patients who identify as Black or African American. So one of the first steps that we did after engaging all of our stakeholders, and this was the idea of one of our community partners, Javina Coleman from Breastfeeding Awareness and Empowerment. She's one of the co-founders and has been an inspirational leader in this work, was really to first start and better understand and reflect on the root causes of inequities and the historical context of racism in reproductive health. So we first started this work with a workshop on racial and reproductive justice called What's Going On? Racism and Infant Feeding Choices. And we held this workshop. It was supported by our neonatal equity group as well as our OB equity groups. And this education served as the foundation for all of the equity work that we have done moving forward. It was an incredibly engaging and eye-opening session, and we had over 50 participants engage with us and learn together. For us, it was critical, and I think for this work, it's critical to center the work around the patient voice. And there's several ways to do it, as you know. You can engage with patient family advisory councils if you have them. If there's patients of diverse backgrounds in these groups, you can include families in your stakeholder group. And another option is to also ask families through things like interviews, focus groups, surveys. And so for this particular work, we went the route of conducting interviews to really get a large breadth and get some depth and as far as what families' feeding journeys have been, what factors inform their current feeding practices, and also to get direct feedback from families. And as we've been doing this work, we've kept this caution in mind, where the goal really isn't to create generalizations of route groups. More so, it's to learn about the diversity of lived experience and to center patients. As I mentioned, we've been so lucky to work with inspiring community organizations that are pictured here. So Breastfeeding Awareness and Empowerment is a grassroots organization that was formed to empower breastfeeding in the Black community. Been working with Maternity Care Coalition and Reclaim Black Motherhood, which is a local organization. And I know that there's incredible organizations in Georgia. I'm so excited to also hear about the incredible groups. But I will say these community hospital partnerships have been pivotal to this work. These partners have enriched our work, our thinking with the incredible perspective, experience, and expertise that they have. They've had a very powerful and respected voice in all of our discussions, but especially those around racism and bias. They've helped us stay centered around the patient, and they've reminded us to keep thinking about systems and not individuals, which is especially helpful as we were developing our driver diagram for our specific project. So here you can see the first draft of our driver diagram, which we developed collaboratively. And you can see here a list of the primary drivers that we had first come up with together as a group. So it includes drivers like prenatal care, family support, peer support, postnatal care, maternal physical and mental health, social determinants of health, relationship with the healthcare system, and previous experiences. So as we reviewed this draft as a group, our community partners spoke up and really challenged us to think more about systems and processes. They pointed out that we were still putting blame on individuals and communities. And I will say, after a lot of collaboration, here you can see our current working draft, where it includes racism and bias as primary drivers in the prenatal care setting, postnatal care setting, thinking about social determinants of health, support, and previous and historical experiences. And you can see here there is an arrow showing the development from one draft to one draft several versions later. But I will say it was certainly not that straightforward, and it was through challenging discussions, learning and unlearning that we reached our current draft. And I will say calling out racism and bias in our hospital system was a critical first step. So we currently have 3 change ideas that we're currently developing as we finish coding our patient interviews. So one is evaluating our policies and practices for racism and bias. We're also revising our marketing materials to ensure that they reflect our patient population. And then this has been the most active change idea that we're working on, which is improving our lactation communication approach to instead use a trauma-informed care approach. And as I'm sure many of you have heard about trauma-informed care, this framework really emphasizes and puts forward that trauma is very widespread, and moving from this idea of what's wrong with you to what has happened to you. And so we've been working on trying to identify trauma-informed care training that we can bring to our providers in women's health, as well as in our pediatrics provider, and make it not only something that is how we approach our lactation communication, but really how we approach all of our communication with families. So as I mentioned, we have been conducting patient interviews, and I wanted to share a little bit about what we've been learning. As I mentioned, the goal was really to learn from families about their feeding experiences, factors that inform their current feeding practices, and get direct feedback. We ended up co-designing our interview guide with our community partners. The 2 specific groups are listed there. And one of our community partners, Parsha Holland, who founded Reclaim Black Motherhood, was actually able to conduct the interviews and did an incredible job in conducting the interviews in a trauma-informed way with all of her expertise and experience as a community partner. We were able to secure local and national funding to do this work, and ultimately interviewed 30 families postpartum. And this included families who were providing their babies breast milk or human milk, mixed feeding, as well as formula only from the get-go, because our goal was to learn from all the different experiences. I will say we learned so much from families. I will say our initial hypothesis was really focused on needing to improve prenatal education so that families could better understand the benefits of breast milk and breastfeeding, or human milk and breastfeeding. I will say, after hearing from families, we learned that a lot of families know about the benefits of breast milk. And really that there is this critical period that spans, prenatal period, inpatient, and early postpartum, where families are making decisions and having experiences that are expected and unexpected, that is shaping how they're feeding their infants in their context, in the context of their own lives, in the context of their lives with other children, in the workplace, and within their community. And families have expressed needing anticipatory guidance and support that's more seamlessly integrated, that's more supportive, that's more realistic and fit for the real world and trauma informed. And this has completely shaped this conceptual framework, which we were able to learn from directly from families, has completely changed how we're approaching our next steps, and our interventions that we're working on. So what's next? Right now, I mentioned the primary focus, as we're finishing coding our last interviews, has been really focused on bringing trauma-informed care training to all providers in women's health and pediatrics. We also have other ideas that we've been working to prioritize, and a lot of these ideas came from, again, straight from families, as from our interviews. So thinking of ways to better integrate our community partners and resources in the community, adapting our counseling approach so that's more balanced, less judgmental, more realistic, more supportive, thinking about how we include support people, thinking about how we provide postpartum lactation support. The system, at least here, is quite fragmented, and there are so many great community resources and so many other lactation resources. So how can we better integrate these resources and supports into our care models? How do we provide pumping support for parents who have other children? And then how do we best disseminate information? Families we're sharing a lot of the social media resources that they're using. So are there ways to leverage social media? Are there other multimedia materials that would be helpful? So all that to say, it's been an incredible journey learning. We've continued to collect data and see sort of where our baseline is. I think we're just moving into the phase of change, of testing and our change ideas. And like I mentioned, the first one being our trauma-informed care training. You can see the timeline here. I think this time that we've spent doing contextual inquiry has been very well worth it. However, it has taken us some time. I will say one asterisk for why it has taken us this much time is we ended up actually doing our interviews formally. So did it as a formal qualitative study, which I don't think you need to do most of the time. I think I was also in a master's program, so I think this also, we did it in a more formal way, and also with the hopes that this information can be disseminated and potentially be helpful for other hospitals and other communities. And so I will say you can typically, as you know, do interviews more informally and be able to get the contextual inquiry piece done in a quicker manner. I do think that as we've done this work, we're also thinking about other variables and other outcomes that I think would be helpful. Potentially, I'm not sure that focusing fully on initiation rate is potentially where we're going to make the most change. I think there's in a really significant drop in our breastfeeding, any breast milk, even at the outpatient level once families are discharged home. But I think looking at our exclusivity rates or any breast milk, even at the point of discharge from the newborn nursery, I think will probably be one of our next targets that we'll be tracking more diligently. And then also thinking about other variables to stratify, such as parity, as we've been seeing that a lot of the families who are formula only from the very beginning are families that have other children. And so that has been an anecdotal observation. And so we're working to stratify our data to explore that hypothesis. So with that, I'll share some successes and challenges. My mentor, Dr. Chris, mentioned once jokingly that a lot of this human milk and breastfeeding work can feel like you're trying to boil the ocean. And she said it's because you're actually trying to boil the ocean. But as this meme says, how do you boil the ocean? 1 cup at a time. And I'm really proud of the work that our team has done. We've had several successes, including, I think, the incredible team that we've built that's been interdisciplinary, collaborative, and really has spanned disciplines, has spanned specialties, and we've really come together for a common goal. We've had leadership support from all of our different disciplines. We've had incredible community partners that has completely changed the direction of our work, and our patient interviews has provided such important information and data that has also helped in steering the direction of our group. I think we've also had a pretty robust data infrastructure and I think we've been able to request data in a pretty seamless way, and I think that has been one of the successes, and I think one thing from our health system that has been helpful in this work. I think for thinking about challenges, I think conceptual inquiry does take time, but it is necessary, and I mentioned why ours took especially a bit more time. I think another challenge that we've been thinking about is sort of the sustainability of the funding. As you know, I think it's really important as we work with community partners, as we work with families, compensating folks for their time and their expertise is important. So, we've had funding for the work we've done thus far, but how do we keep those relationships moving forward? And I think one other thing that we've been working on trying to think through is how to integrate families into the task force, wanting to make sure that the group, we prepared families, that we are supportive, that we are welcoming, especially as all of this work has been primarily virtual. And so that's still something that we're working through as a team. And so with that, this work is ongoing, and I wanted to acknowledge all the patients and families, as well as our task force, our community partners, mentors, our funders. And I'd love to open it up for discussion and questions, and would love to learn more about your work and hear your thoughts and experiences in Georgia. So thank you so much for listening.
Thank you so much, Dr. Pena. It looks like there are some questions in the chat, and then we can go ahead, we can open up to other questions either in the chat or you can come off mute and ask. The one that we have in the chat is, in the ICU at CHOPS, do a majority of the nurses who work there have their IBCLC or their CLC?
That's a great question. So not all of them have their IBCLC. I don't know specifically about the CLC. I know all of our nurses, even in in the NICU and also in the postpartum, like L&D, have some sort of additional breastfeeding training that so they're able to provide support to every postpartum parent. Like that's an additional support. And then for parents that have expressed any desire to have to breastfeed their baby or to provide any human milk, then there's a specific IBCLC that will then see that patient.
That was a fantastic presentation. I had two questions. The first one was, for centers that are joining us that are thinking about how can we center the family and the patient at the work, what are the types of questions you might suggest if you're doing these non-formal interviews to try to get to get the experiences and capture them from those patients and families that are cared for in the variety of settings? Do you have suggestions on what kinds of questions might be helpful for teams to ask?
Sure. So I think, a lot of our interview was open-ended. So it was, tell me about where you first learned about human milk or breastfeeding, and tell me a bit about how you thought about how you were going to feed your baby when you were pregnant. What was that like when you came, sort of really just exploring and approaching it with curiosity. I will say our community partners were extremely helpful in developing our interview guide and even thinking about like what questions are actually helpful in trying to probe and learn from families. But I would say, I think even just approaching it as, who spoke with you about this? What was that conversation like? What influenced how you thought you wanted to feed your baby? How did things change? I think that even just approaching it from a point of curiosity, I think was very fruitful. And I think using and building relationships with community partners who are hearing what families' experiences are like all the time, I think was also really helpful to guide the specific areas where they may hear like, oh, we're noticing that a lot of families are telling us this, so that might be an extra area to probe a bit further. That may be specific to your community, for example. And so it was very helpful. And they were also very helpful in thinking about how to ask things in a sensitive way, especially when it comes to asking about prior experiences with breastfeeding, because there could have been trauma with prior deliveries or prior pregnancies. And so I think having somebody help you in navigating those conversations, I think specifically with community partners, they were an extremely helpful resource and taught us a lot.
Thanks, that's really helpful. And the second question is, one thing for all statewide PQCs, equity has become, the CDCs who support a lot of the statewide perinatal quality collaboratives, including ours here in Georgia, are really emphasizing a focus on health equity. And I think this really touches on why that's important. But you mentioned in some of your work the span of kind of prenatal to postnatal, and I wonder if you could touch on how to navigate that. For many of our hospitals, there might be a lot of discontinuity across those different settings in terms of kind of the transitions of care. So I wonder if you could tell us that kind of how you address some of that.
Yeah, no, that's a really great point. I think with the current hospital system, this work is being done in. The majority of our patients are seen like in 3 clinics, or like seen either by OBs, which they have 2 clinics. OB or their associated providers. There's family medicine, and then we have a smaller subset of patients who are uninsured or underinsured who are seen at health centers. So our primary work has focused on the three like clinics, and so we haven't specifically navigated how to approach, for example, our interventions such that they're cohesive across different settings if they're not in the same health system. But I would love to brainstorm further. I think that's where like your Department of Public, groups like this GaPQC could be helpful as you're thinking about, we're piloting this specific approach to our conversations on prenatal counseling on lactation. This is what we've done here, and if that's something that can be spread, I think that may be a helpful way to mitigate when potentially different sites are not perfectly affiliated or aligned with, for example, delivery hospital or postpartum care. But yeah, that would be one initial thought I'd have, whether it's a forum like this might be helpful, or if there's outreach work that specific hospitals can have to spread sort of the approach and the language that folks are using. Because I think there is benefit to trying to be being more consistent in an approach, because I think families, when they come here, families remember all be in alignment. I think it only serves to help families better. I don't know if that answers your question.
Yeah, that was helpful. I think 2 takeaways for our teams as they embark on the, one is thinking of how you can capture and how you can learn from your patients and families. And I think the second is thinking about working outside the walls of the hospital, which I think has been emphasized. And so things for our teams to start considering.
Great. Thank you again, Dr. Pena. Like Dr. Patel just said, there's a lot here for our teams, a lot we can learn from, and things that we can consider as we move forward with our initiative. So thank you. We're excited to have you in Georgia soon.
Thank you. I'm looking forward to it. Thank you so much for the invitation. And I'm so excited to see the work that this collaborative is working on. It was just even so energizing to hear the opening remarks. So I look forward to working with you all soon.
Great. And then just one more announcement from us to hospital teams. Next month's webinar, as Claire mentioned, July 12th, we'll be walking through a gap analysis and self-assessment and setting a SMART aim. As always, thank you to all of you for participating. And if you have any questions, feel free to email me at any time. So thank you all. Have a wonderful afternoon.